Good morning, and welcome to TCT Asia Pacific here in Seoul, South Korea. My name is Krishna Rocha-Singh. I'm an interventional cardiologist from Springfield, Illinois, and it is my distinct pleasure to introduce my three colleagues to my left who will discuss some of the controversies, the ongoing controversies of renal artery stenting. The first colleague to my left is Dr. Richard Heuser. He's a professor of medicine at the University of Arizona. Welcome, Richard.
Thank you.
To his left is Dr. Michael Jaff, my colleague from Massachusetts General Hospital. He's a professor of medicine and runs the program at Mass General. And welcome, Michael.
Thank you, Krishna.
And finally, my colleague, Dr. John Laird. He is a professor of medicine at the University of California, Davis in Sacramento, and he runs the vascular program there. So we have three eminent individuals who have had long-standing experience in renal innervations in general and renal stenting in particular. And so what we'd like to do is understand a little bit about the ongoing controversy in the face of what has been released just last November, a large million-dollar multi-center NIH funding trial, and explore really how much we have learned that will impact our practices with regards to the patients we treat with renal artery stenosis. Now, I have some introductory slides that I will use only to promote the conversation and catalyze some of the questions that we are going to pursue. So we understand some of the complexity relative to renal artery stenting and who we treat and the endpoints are multifactorial. We start with a renal artery stenosis, and we're going to explore some of the issues that not all renal artery stenoses are created equal, and understand that simply having either a unilateral or bilateral stenosis of a very varying degree of complexity and severity is something that we need to consider. Now, most of us consider hypertension to be associated with renal artery stenosis, and we'll explore that. And these many times are true, and related, and or unrelated. And so we have to understand that. And finally, we have the overlying issue that these patients who have renal artery stenosis have concomitant hypertension, diabetes, may have a component of diabetic or hypertensive nephropathy, and tease that out with regards to the intervention of the renal artery stenosis and how it impacts both hypertension and renal failure. So we have renal artery stenosis and hypertension as an overlapping issue. We have that's influencing on renal insufficiency and its progression over time towards presumably end-stage renal disease, and then hypertension and renal insufficiency. And we haven't even mentioned the impact with regards to this and volume and salt metabolism and heart failure. So I want to, in general, go over some very basic points and start the conversation with understanding choral and astral and what they tell us, and more importantly, what they don't tell us, and issues of how this helps us in selecting the optimal patient. And then finally, I think this is going to resonate again and again and again, the importance of trial design and the questions asked and the recommendations that we can tease out. So I'd like to start with my colleague, Dr. Jaff. As by way of introduction, Dr. Jaff was on the steering committee and was the duplex Doppler core lab for CORAL. Michael, it was a very challenging trial. It took longer than expected. It had multiple amendments to it. Give us your insight, understanding, it was refresh my mind, it was almost 7 years or a decade?
I think from the very first concept to the time it was presented was about 11 years.
Long time.
Really long time.
So give us your impression, understanding a decade's worth of trials and how the field evolved and how our understanding evolved and how this impacts your practice, because you see, as a vascular internist who really has no dog in the fight, so to speak, how you interpret the data and how you refer patients to your interventionalists for an intervention.
So I think what CORAL did was confirm what I'm sure the four of us do in practice long before CORAL was ever completed. What CORAL told us, Krishna, is if you have a patient with renal artery stenosis and hypertension, and you have a choice between first thing you do is stent versus optimizing medical therapy to try and control blood pressure, you're going to give a trial of medical therapy first. So I actually don't think Coral changed the thing. I think it confirmed that that practice is the right practice. Now the question, of course, is what happens if you can't control the blood pressure? Either because you just can't, or the patient can't afford their medications, or can't tolerate their medications, or they develop things like progressive vasotemia, renal atrophy, things like that. What do you do then? Coral doesn't talk about that. What Coral says is give a good trial of medical therapy first.
Very good.
But the very low crossover rate in Coral would suggest that most of the time we can manage people well with medical therapy, assuming that it's good medical therapy, because a very low percentage of patients crossed over from medical therapy to stenting in that trial, and certainly it was discouraged, but the numbers were quite low.
So let's take that point there with regards to patient compliance, with regards to patient on maximal medical therapy. We've just finished another huge trial that I think focuses on this point, the Simplicity 3 trial. I think we understand that patients' ability, and Dr. Heuser, I like your point with regards to your practice, we understand that resistant hypertension and its definition may really correlate to the silent non-compliant patient. And one of the problems here is how we really change behavior of patients with regards to something as ethereal as systolic blood pressure and taking medicine. How do you manage, or how do you deal with your patients with regards to the issue of non-compliance, which is a huge problem?
Well, I think the best way to deal with the issue of non-compliance is get a patient in a study, because if we see these studies, unbelievable likelihood of them taking the medications as directed, something I never see in practice, and none of us see in practice. The interesting thing is that I think if we truly see the patients that are non-compliant, probably about 50% of our patients are non-compliant, whether in hypertensive drugs or other kind of medications. But in the case of hypertension, resistant hypertension, it's been said that's about a 50% compliance.
Right. So a very interesting point. So you bring up what I think all of us understand, something called the Hawthorne effect,
Yes.
whereby patients get put into clinical trials, and just by observation and they're signing a consent, their compliance and performance actually improves. So we have to tease that effect out, and we really don't know the veracity of it or the duration of that effect. So that's very, very important. So let's, Dr. Laird, we had some very interesting conversations yesterday at a session, some very provocative points with regards to how this trial has affected you. You made a statement that you felt that there would be a very, very rare patient, and let's talk about unilateral versus bilateral renal artery stenosis. You made the statement that you felt there would be a very rare patient where you felt compelled to treat a patient with unilateral renal artery stenosis. Expound a little bit on that, and what led you to believe that from your experience, or was it Coral that helped you with that?
Well, I think it's a multitude of things. And first, we're talking about atherosclerotic disease and not fibromuscular dysplasia, which I think is a different animal in terms of how we manage it. But I think part of it's the data from Astral and Coral that influences me, and it has influenced me to a certain extent. Part of it is clinical experience now over many years watching patients with unilateral renal artery stenosis and treating them medically and realizing that actually they can do quite well, and they don't seem to progress to the extent that I thought they had previously in terms of progressing to more severe renal artery stenosis or renal artery occlusion. And I think the propensity of data would suggest that the patients who really do better with intervention are the patients with critical bilateral disease, with pulmonary edema, with progressive renal failure, or with severe hypertension. I think those are the ones that actually really get better with an intervention. I think it's less clear that the patient with just a unilateral renal artery stenosis and normal renal function benefits from our interventions.
I want to key in a word that you just said, and I'd like to ask Dr. Jaff about the definition of critical. Now, we understand that doctors and the ocular stenotic reflex is quite well developed. And core lab assessments of doctors' assessment of renal artery stenosis and core lab adjudication can be discrepant as much as 30%. As the core lab, one of the criticisms that has been labeled, that nailed Coral, is that this issue of critical was difficult to really nail down, and a lot of the patients that were enrolled had moderate renal artery stenosis. Help us with that and how this we deal with the physiologic nature of a stenosis and its attributes to what we're discussing here.
Yeah, you know, as time goes on in my career, I start to succumb more to this concept that you'd rather get a trial done and learn what you can than not get it done because you set the rules so hard. If you set the entry-level anatomic stenosis in coral to 80% or greater by core lab adjudication, imagine how long that trial would have taken. It's hard to get an 80% or greater stenosis on an angiogram at a core lab for renal artery disease. And so I think it's not surprising that the severity of stenosis in coral was around 60-62%. And that's kind of what it set out to do. So accept it as the limitation that it was, right? We said greater than 60% renal artery stenosis with hypertension, or blood pressures with chronic kidney disease with greater than 60%. So I think the more severe you make the stenosis at entry level, the longer it's going to take to get patients into the trial, and therefore the less likely you're ever going to get to an answer.
Well, so that's a very provocative statement, because what you're suggesting is that we answer who not to treat, and then we have some assumption as who we should treat. You were very instrumental in the Hercules trial. This was a PMA trial by Abbott that looked at really a different cohort of patients for failed renal angioplasty and the application of renal stent. But having said that, I think, and I'd like you to expound a little bit on what we learned about the selection of patients with renal artery stenosis, and more particular, the assessment of their baseline blood pressures and subsequent response, because I think that's very, very telling.
Yeah. So remember, though, I mean, you can't put Hercules and Coral in the same category, right?
Sure.
I mean, the rigor of the trials were entirely different. The oversight was entirely different. But having said that, there were some things put into Hercules that I think added to the science. So one that I think was very helpful was putting out BNP as not a predictor, right? I mean, that put the issue to rest. It doesn't help you determine outcomes. But we absolutely did find that in patients who had really, really high blood pressure at entry, 180 or greater systolic, they had very impressive reductions in blood pressure out to 3 years now. Now, did they do it with ambulatory blood pressure monitoring? Did they? No, of course not. But given the limitations of the trial, I think it goes to the point that John said, and that Richard believes, that of this population of patients, there are some in whom you absolutely believe that medical therapy, when failed, intervention offers an option. And I think that's the strategy you have to take away from this.
You know, it's interesting, Michael. You were earlier sort of saying, you know, we didn't contribute that much with Coral. We didn't see this. Maybe you didn't exactly say that, but
no,
one of the things that it clearly helped us with is that when I have a patient who comes in with peripheral arterial disease, has hypertension, maybe on a couple agents, maybe 3 agents, I haven't really been concerned about the control of the blood pressure. My central blood pressure is 130/80. I do an abdominal angiogram, and sure enough, there's about a 70% stenosis of the renal artery. In the past, the fellows would be all over that. Oh, I'm going to treat this. Well, we know we don't have to treat it. That's very helpful.
Agreed.
That's extremely helpful. And I think that the other thing of Coral that I really like is the fact that follow the patients out. If they had a stent and really had resistant hypertension, actually they do better than with medical therapy. Am I right?
Well, they do better because their blood pressure was a little bit lower.
Right.
Yeah, I mean, clinically, probably not that big a difference, but statistically it did make a difference. I do think that there are some papers that are going to be coming out of Coral, which is common in NIH trials, that will add to the basic understanding. So, for example, there's going to be a bunch of stuff on ultrasound and the ability to predict certain outcomes with ultrasound that we didn't know up until Coral. So I think there will be some good things that will help us, but the bottom line is, we learned a lot, we suffered a lot.
So Dr. Heuser, going back to your question that the patients with renal stenting actually got better with regards to their blood pressure, we also understand the patient who had an angiogram,
right,
and all we did is do an angiogram. We pulled this catheter out.
Right.
They had an equivalent drop of 11 millimeters of mercury in blood pressure at 3 months, and it persisted.
Right.
So your comment with regards to subjecting these patients to a renal intervention, and some of us, I think all of us, the expertise here at this table would have a very, very low complication rate. But in sites that were, I think, in excess of 100, I think we see a variety of care. So would you agree, getting back to your initial point, that just putting into a patient's trial,
right,
you're going to expect a 10 millimeter drop in blood pressure? Although to Michael's point, we did not, the rigor with which that was assessed was not, I think, like a primary hypertension trial, because this was a hard endpoints trial, not a blood pressure trial. So I'd like to move on here and discuss a little bit about the second part of the anatomic criteria and the physiology, if you will, that will define or predict that the patient that you are going to treat is going to actually manifest a clinical effect. And the assumption obviously is, Michael, that A is connected to B, that if we believe the Framingham data, that we drop somebody's blood pressure, and over in a large population, that drop in blood pressure will translate into a reduction in hard clinical endpoints. So let's ask the first question on the table. Dr. Laird, do you use any type of physiological assessment to assess whether you believe this patient is going to respond prior to intervening? And specifically, we're talking about data with regards to dopamine-induced blood pressure and then a gradient. Help us with that.
Well, I must confess that I don't, and I don't actually believe in it for the most part in terms of using dopamine or provocative agents or doing the equivalent of an FFR in the kidney. It just doesn't make physiologic sense to me. I mean, it's one thing when you have an organ with a changing, blood and oxygen requirements, such as the heart or the legs, where, giving provocative agents to try and simulate that sort of effect in the cath lab makes sense. To me, with a kidney, that doesn't make sense. So I use pressure wires when I'm performing renal angioplasty in FMD patients, where clearly the angiogram can be misleading or may not give you any good idea of the severity of the obstruction with FMD. With an angiogram, I think if it's severe, it's evident, and I'll treat it. And most of the time now, if you have a moderate stenosis in the renal artery, it probably doesn't need to be treated.
Okay. Very good. We had a discussion that initially the trial design, and this is one of the issues with regards to coral, initially used distal protection. The thought being, and this came out of a paper from Dr. Cooper that suggested if you did use a distal protection in conjunction with antiplatelet agents, that there was actually a suggestive improvement. Tell us if you were to, in a teaching hospital, pursue, in let's say a bilateral, there was no question that this patient needed it. What is your use or disuse, if it will, of distal protection in these patients?
Well, I think the biggest problem is that we don't have a distal protection device that's well designed or well suited for the renal arteries, and the anatomy often is problematic because you have early bifurcations or more than one renal artery, so you can only protect part of the kidney at a given time. So the number of cases that are anatomically suitable for embolic protection are less than we'd like. But having said that, we did a trial with the FibroNet device, which I think was nicely suited for renal artery intervention, and found that we got some particulate in almost every case. And I think some of the data from Dr. Holden and others would suggest that, and Dr. Henry, that you do get a significant amount of material when you use embolic protection devices during renal artery intervention. So I think it's a good idea, and if I have a higher risk case, I will use embolic protection if the anatomy will allow it.
Yeah. Dr. Heuser?
Well, it's interesting that you mentioned that. We have over the years seen that in saphenous vein graft studies and carotid studies, et cetera. And most recently, we've seen that in the analysis of embolic phenomena during TAVR. You don't just get particulate, you get pieces of the valve, big pieces. Unfortunately, we need real endpoints, and that is not going to translate. Well, can't you see we always have this embolic material? As a clinician, I see it, but it's interesting. For in case of TAVR, actually people are looking at hard endpoints, cognitive changes, and placebo versus an embolic protection device. So I think that's going to be a situation both with any application of embolic protection. So it's not enough to say you get material.
It's
I think we're going to need more data.
in renal artery intervention because there isn't a good endpoint.
Correct.
That's always been the trouble.
So I want to move and change the direction of our interesting conversation here. Michael, you know that CMS very much factors into our lives, and that during the execution of this trial, CMS put out basically a shot across the bow, if you will, suggesting to doctors that we needed some data in order for them to continue to reimburse for this therapy. They put out a national coverage decision that basically shook the tree a little bit. We see here on this slide set the societal guidelines. I don't know if CMS really looks at societal guidelines. We try to obviously have these as data-based, and we see here hypertension, atherosclerotic nephropathy, and cardiac destabilization. Give us your projection, since you sit on many times sit on some of these writing committees, how you think the bottom line of CORAL will impact these guidelines and what CMS is going to look at.
Well, the only reason I hesitate a little is because I don't know who's going to be running the tiller of CMS. But presuming that their approach is going to stay similar to what they've done in the past, I think this is a high-risk situation for reimbursement for renal artery intervention. And I think it goes to the comment I made and John Laird made, that if you have patients with renal artery disease and hypertension, it's going to be the uncommon patient that actually is going to warrant that. Either you're going to have to make the case for that, or they're just going to say across the bow, we're not going to do it. And you have to petition us to get it paid. I think it's a very high-risk situation.
So the indication for renal stents right now, and I think there have been no new renal stents since Hercules Plus, I recall.
I think that's right.
Several years, half a decade. From a business point of view, you would suggest there are probably never going to be another renal stent put into the marketplace.
Well, I don't think there's going to be another renal stent trial. So, for example, a lot of people have said, why don't we just do the trial that we think we all ought to do?
Yeah.
Even if we came up with a plan and every single interventionist agreed that they'd enroll every patient into it, I don't think we could get a sponsor to cover it. So I don't think it's going to happen.
Right. So you feel that really we're going to have a long road to hoe. It's been the decline in renal interventions has been well documented and established, and probably appropriate for the past half decade. I think several years ago, ACCHA and you were part of the writing of the basically guidelines for abdominal aortography at the time of cardiac catheterization. I think that paper specifically is going to be thrown into the trash. Don't you think?
I do agree.
So let's look over here, and I want to look as we finish up in the next 5 minutes here, some more important points with regards to equipoise. I think one of the issues that we had, I think Dr. Laird, although he wasn't part of the trial, one of the things that was reflected upon was that we had a very difficult time getting patients into this trial. We, as Americans, criticized the Astral trial in its trial design because it specifically stated you randomized patients where you felt you didn't know what to do. I think we had the same issue here, Dr. Heuser. Wouldn't you agree that many doctors had preconceived ideas based on their own experience that they knew what to do and didn't put these patients into the trial, and that was what related to the very protracted duration of this trial. So given that, getting back to Dr. Jaff's point, I think this trial really tells us what not to do as opposed to what to do.
That is a problem, Krishna. And before we started this session, you had asked, were you a CORAL site? I wanted to be a CORAL site, but in order to do it, I needed all of my partners to participate, to enroll patients. And you know what they said? There's no way I'm going to randomize a patient with renal artery stenosis. Number one, they need a stent. Number two, I know they need a stent. Well, guess what? It's sort of like courage. I know that everybody with stable angina needs a stent. Well, we don't know that. And courage was very helpful. CORAL was very helpful. So I think you're exactly right. In other words, the patients that maybe we wanted to be randomized and the physicians that were experienced that maybe we wanted to have in this trial weren't in the trial.
Very good. So let's go here. I want to sum up a little bit some of the critiques here. Obviously, the patient selection and knowing, to your point, who to treat and who not to treat. We looked at the second point being the Hawthorne effect, simply putting a patient in a clinical trial. They did have an established blood pressure change, which was no different from the stent group, which probably meant the stent didn't do a whole lot. There was no additional application. And then the issue of critical stenosis. So I think we have a challenging clinical trial design. I'm not so sure what we've got for our money, understanding this was a multi-million-dollar trial that took over a decade. I think, to Dr. Laird's point, the results have and will change our clinical practice. I think it already has. And the question then becomes, what would you do now to sum up here with this patient, understanding the results of CORAL trial? Because this, frankly, was not, and Michael, correct me if I'm wrong, this was not a typical patient that was put into CORAL.
Actually, a third of the patients fit this criteria.
Third.
Right, bilateral disease, renal function about 1.5, blood pressure 155, which was kind of right on the cusp.
Right.
This patient would have been a candidate.
So given that, I understand it was not the majority.
No.
No, it was a minority. It was going to be a sub-analysis. So, John, let's finish off by saying, would you or would you not refer this patient to renal stenting? Okay, understanding resistant hypertension, blood pressure 155, 62 on hydrochlorothiazide. That's my favorite drug, but it is a diuretic. Yes or no? Intervene, yes or no?
Well, I think we would have a discussion, the patient and I, about an intervention. But I would have to say, based on what we learned from CORAL, I'm not certain that the patient would benefit now as much as I would have thought in the past. As clear-cut as this sounds, as Michael mentioned, some of these patients did make it into CORAL. But we would certainly have a discussion. And at the very least, if we decided not to intervene at the present time, we would monitor this patient very closely, and I would do serial duplex studies.
I'm glad you said to survey this patient, keep him in your fold, get him back every so many quarter. What would then tip you over to say, we need to do this? What would tip you over?
Well, I think a deterioration in the renal function, a drop in the GFR. I do look at kidney length, so I would look at kidney lengths, and if one of the kidneys was shrinking, I would probably intervene. And then if the blood pressure control became worse.
Very good. Michael?
I agree with everything John said. I mean, what CORAL didn't look at was what happened to those in the medical therapy arm, right? Didn't get a stent. What happened to their kidney size over time? Yeah. So wouldn't it be nice to know that if you lost a centimeter in pole-to-pole renal length, that was a marker of failure? That's kind of my tip-off that what it would be, but I would do the same thing John said.
Dr. Heuser, in finishing up, would your colleagues stent this and have this patient at home the next day, or would they actually behave themselves and listen to what CORAL suggested?
They would have them home the same day, and they would have stented both vessels.
Very good. So I think in summary, I think CORAL, if we decide to accept the recommendations for CORAL, we look forward actually to subsequent sub-analyses and publications. I think this continues to be a learning opportunity for all of us. I do think there's some intersection with some of the results and trial design issues. And with that, I'd like to thank all of you for your very insightful comments and contributions to this morning's session. Thank you very much.
Thank you, Krishna.
Thank you.